So hepatic steatosis and laminin mutations are present in about 50% of these patients. Coming next to Wolfram's-like syndrome, 20-year-old gentleman who came looking like type 1 diabetes with polyuria and polydipsia, treated for a number of years. But the striking feature over here was the high sodium. And when you have uncontrolled sugars, you expect pseudo hyponatremia. But the sodium was high. And you can see over here that the urine osmolality is low, indicating a dilute urine. So this patient has diabetes mellitus and diabetes insipidus at the same time. C-peptides were low and GAD was negative. So the sister has more rapid progression with visual loss, optic atrophy, once again diagnosed as type 1, but then the other things kicked in, seizures, and subsequently neurological neuraxis involvement, and passed on at the age of 26 years. So you can see over here the very gross hearing defect, sensorineural hearing defect, and also the OCT showing the thinned out the ganglion layer on the OCT. The atrophic pons in the brainstem is also prominent, and this patient has a Wolfram syndrome mutation. So it's very important when you have a young person, say they don't have ketoacidosis, their C-peptides are low, the imaging is normal. Once again, genetic things should come to the fore. And I'll give you some data on that. So by and large, this is a publication in JCM on Wolfram's, and you can see that they're largely insulin requiring. Occasionally, you have a heterozygote who comes like an autosomal dominant and who may require oral antidiabetic agents, but it is very uncommon. So we now think about the Wolfram's-like syndrome, not the Wolfram's, but the Wolfram's-like, where they have milder disease and can progress to adulthood. There's another nice publication from UP which has shown the Wolfram's syndrome predominance. So look at this graph. This is once again data which has just been sent for publication. You can look at the bottom line which shows the age of onset of diabetes. And then the optic atrophy comes several years later and the hearing deficit comes later. So just imagine at the initial phase in Wolfram's-like syndrome, you would not think of Wolfram's at all. So the importance of genetic testing therefore has been highlighted when you have patients like this. And the cost of genetic testing is coming down with reasonable rapidity. Why is it important to make a diagnosis? Because you can stabilize the endoplasmic reticulum in these patients. You can use valproate. There are studies, phase 2 studies, which have shown that valproate might help. One more medication which I should mention, which has been used in Leber's optic atrophy is ibidinone. So that's another very useful medication which can be used. They can prevent the neurological progression in at least some of these young people. HIV lipodystrophy won't allude too much into this particular condition. It's a little different from the hereditary lipodystrophy. For one, the diabetes is usually mild. The insulin resistance is also not as severe as what you see in the congenital forms of lipodystrophy. And they usually don't have much hepatic involvement. So that's the thing. We now have an 8-year follow-up and which should be published very soon. Generally, the diabetes is very mild and non-progressive and the complication rates are not too bad. And these patients with HIV actually do pretty well when they are on ART and don't seem to succumb to early metabolic complications. Finally, I'll come to type 5 diabetes. This particular condition first reported in 1955. Not perhaps first reported by 1955 by a British person in Jamaica by name Hugh Jones. But interestingly, you should read about Edin Lanceroy. I hope I got the pronunciation correct. He's a gentleman who described 2 forms of diabetes almost 200 years back. One was clearly type 2 diabetes, but the other was a lean form of diabetes where the patients had a fair degree of longevity. So it didn't look like type 1 diabetes and they didn't succumb to ketoacidosis or any kind of catastrophic disorder. So the question is, did that condition with Edin Lanceroy, was it the so-called malnutrition modulated or type 5 diabetes? Was it actually more common, say, many years back? That is Dr. Bajaj, who pushed they literally pushed this into the WHO classification of malnutrition-related diabetes. I wish I had a few more photographs showing Samal and Tripati, who are very much part of the Eastern Belt and done a lot of work over here, and a very nice review written by Charlotte Bowama from Rwanda on this particular condition. So, it was of course taken off the WHO classification, and subsequently, following a physiological study which was done by our group as well as the group at Albert Einstein in New York, there was more attention driven towards this. So, in April, just 3 months back, type 5 diabetes was declared as a potential condition which required study. This is not a new condition. It's not a rediscovery. It is something which we seem to understand a little bit more than what we did before. If you want to read up a bit about it, these are the upcoming publications in Lancet Global Health in a month's time, IGM in another month, the Scientific American publication 2023, and the Physiology publication which was published just 2 months back. So I'll just allude to what we know about the pathogenesis, and I think we know a lot about the pathogenesis, the pathophysiology, but we're not certain about the treatment. So the thing is, if you look at the risk for type 2 diabetes, you have a list of 21 conditions, and each of them has a well-validated reference. But there's one particular factor here, which I'm going to give as an overlap phenomena, which contributes to both type 2 and now what we call type 5 today. So inequity, global inequity, has an important impact on the evolution of type 2 as well as what I'm going to be talking of, type 5 diabetes. I've already talked about the thrifty phenotype. So the Barker hypothesis. If you're born low birth weight, your risk of accruing more body fat and developing obesity, hypertension and diabetes later on, provided you're well fed after delivery, is greater. And this has been seen in multiple cohorts across the world in times of war, in times of famine. This is the Dutch hunger winter, wherein women from Netherlands had calories of 400 calories per day and subsequently had a very high risk of their babies when they were pregnant developing hypertension and diabetes several years later. These are figures from India. We do have a proportion of undernutrition, and we do also have a proportion of low birth weight in our country, which is fairly significant. Now, this is some of the work which was done about 15 years ago by our group, looking at individuals who are born low birth weight. We had a large birth cohort at the age of 20 years. We did 60 low birth weight and 60 normal birth weight at the age of 20. These are very laborious tests. The hyperinsulinic euglycemic clamp studies for looking at glucose insulin sensitivity, indirect calorimetry and NMR spectroscopy. And that was my resident that time, Dr. Spurgeon, who was actively involved with this. So what we found very interestingly was, with all these elaborate studies, there was no difference in energy expenditure, but between the two groups who both had the same BMI, very lean but muscular individuals at the age of 20, the low birth weight was shorter and lighter, had reduced muscle mass at the age of 20, mildly increased diastolic blood pressure, percentage body fat was slightly higher, and the low birth weight individuals had a habitual low protein intake. And this is not due to a socioeconomic difference. They had an aversion towards taking a higher protein diet. When we put them on a bicycle, and that's my community health professor colleague, Venkatrava, who actually did this study with us, we found that in a period of 2 months, that the low birth weight group had an increase in muscle mass and a reduction in fat, and the energy expenditure actually improved. So low birth weight individuals do have an improvement in their muscle mass, and therefore the muscles do respond to exercise. And this is important from a therapeutic point of view later on, when we think of lean individuals or malnourished individuals, that exercise is of some benefit. Roshan, along with our group, did this energy expenditure, did the measurement of micro quantities of fat in the liver and the muscle. And the low birth weight individuals have a very low content of fat on NMR spect. 20% have no fat in the liver. So the risk factor for fatty liver, etc., comes only when there's significantly increased dietary intake of carbohydrates over a prolonged period of time. It's not intrinsically there.